I'm going to talk about IBS and an overview of the medical management of IBS. I'm going to try and do it in about half an hour. So what we'll talk about is, first of all, what irritable bowel syndrome is. Then we'll have a little look at the epidemiology of it, some of the pathophysiology involved in IBS, some general principles about management, a little overview of the medical management of IBS, and then just touch on dietary intervention, because of course that's really what the rest of the day is about. So what is IBS? Well, IBS is defined as a functional bowel disorder, and we'll talk a little bit more about functional bowel disorders in a minute, in which recurrent abdominal pain is associated with defecation or a change in bowel habit. And the disordered bowel habits are typically present, so that is constipation, diarrhea, a mix of the two, as are other symptoms such as bloating and distension. And that's from the Rome 4 criteria. And the Rome Foundation is a group of interested specialists in functional gut disorders who get together once every few years and try to make definitions out of what is a very complicated area, that is functional bowel disorders. And I show you this slide not for you to read, but just to demonstrate that the functional bowel and gut disorders cover a huge range of things. And you can see there that circled in red is irritable bowel syndrome, and that accounts for just 4 of the different functional gastrointestinal disorders, and there's about 50 or something other ones out there. So IBS itself actually is a very well defined and slightly small part of the totality of the functional disorders that we deal with. Functional gut disorders produce a variety of symptoms, so pain is very common. Certainly with more upper gut disorders we see nausea and vomiting. As we move down through the gut we get some of the more lower GI things, so bloating, wind, diarrhea and constipation. But the key is that these exist in the absence of any structural abnormality or inflammation or anything like that. And that's really where part of the trouble comes in, because due to their nature, there really aren't any good diagnostic tests, at least not definitive tests that enable us to say, yes, you have this diagnosis. It's a diagnosis that is based effectively on recognizing the constellation of symptoms that are present that then gives you that diagnosis. The trouble is doctors and indeed patients don't like that. It's much easier to do a test that says, look, your blood glucose is this high after a load of glucose, therefore you have diabetes, than to sit down and say to someone, we've done all these tests and they're all normal and therefore you have this condition. And I think that's one of the reasons why the functional gut disorders, and particularly irritable bowel syndrome, are very poorly understood, both by health professionals and by patients as well. And because of that, and that difficulty of talking about what is essentially a difficult diagnosis, that leads to doctor-patient conflict, and that leads to problems in turn, such as inappropriate investigation and treatment. And then it's finally compounded by the fact that these conditions aren't easy to treat. It's not like you've got an infection where you can simply give some antibiotics and make things go away. It involves a complex, multi-system and multifactorial disorder that requires really a quite subtle approach in some patients. So this is how we make the diagnosis. I briefly mentioned the Rome criteria earlier, and we've been using Rome 3 for quite some time now. As you can see on the left there, the Rome 3 criteria used to talk about abdominal pain or discomfort, but with the recent update, it's now abdominal pain. How much does that matter in reality? I don't think it really matters very much. You know, you've got to talk to the patients about it. They used to say 3 days per month in the last 3 months. They now say 1 day per week in the last 3 months. Clearly they had to do something when they got together, so they've made these little tweaks to make their little stay in Rome worthwhile, I guess. In the past, the pain or discomfort used to improve with defecation. Now it's related to defecation. In the past, you used to get onset of the change in stool frequency associated with the pain. Now it's just associated with a change in stool frequency or form. So you can see there's some subtle tweaks there, but you can also see that in fact the criteria are quite strict. And sometimes it is useful when you're talking to patients. Can you say, look, come on, this is real actually, and these are the strict definitions. And in fact, What I often do is sit down with patients and they'll say, oh, you know, I've been told I've just got IBS. Often that word just is used. There's no just about it. Sometimes irritable bowel syndrome can be a really disabling disorder. But you sit down and say, well, actually, you don't have IBS because by these criteria you don't. And then you go into the whole thing about what diagnosing functional gut disorders is. Of course, those aren't the only symptoms that you get, and other symptoms are supportive of diagnosis of IBS. So these things, so abnormal stool frequency, that's less than 3 times a week, more than 3 times a day, abnormal stool form, straining on defecation, urgency, feeling of incomplete evacuation, as one of my old bosses used to say when I was a trainee. He used to call it rectal dissatisfaction, which is a nice term, but I think it describes it very well. It's that feeling of having gone to the toilet and then thinking, oh God, but I haven't quite gone to the toilet properly. Mucus production is very, very common, as is bloating. But it's all in the absence of these red flags, so anemia, masses in the abdomen, raised inflammatory markers, weight loss, which is something that we don't like in general, rectal bleeding, family history of bowel or ovarian cancer, and a recent change, particularly in older people. When you have these things, you need to be thinking, actually, I do need to make sure there's nothing else going on here. You can still have IBS with some of these things, you know, rectal bleeding can come from piles, but you need to be thinking carefully about making a diagnosis of IBS without proper investigation. IBS is subtyped beyond that by stool form. As you can see from this graphic here, we really split it into 4 things. If your predominant stool form is constipation, then it's IBS-C. If it's predominantly loose stool, it's IBS-D. If it's mixed between those sorts, it's IBS-M. And then if it's neither of those particularly, then it's IBS unclassified. So what about the epidemiology of IBS? Well, is it common? Yes, not only is it common, but it's a global problem, as you can see here. Perhaps more prevalent in the developed world, although there are some hotspots of IBS all over the place. But as you can see, it's a problem that we recognise all over the world. It does change in terms of age, and it's also more common in general in women other than men. Although if you look at these functional gut disorders here, you'll see that men, for example, have more functional diarrhea, and I think that rings true. You know, if you sit in clinic and you see patient after patient with functional gut disorders, men generally are more likely to have diarrhea, women are more likely to be constipated. But things that increase with age will be defecatory disorders, constipation, esophageal problems, so esophageal dysmotility, all the things that you expect perhaps as people get older. The other thing that we see about the epidemiology of IBS is that you see different healthcare seeking behaviour in people with functional gut disorders. This is a graph showing how frequently people visit doctors, and it looks at people on the left there with IBS and on the right people who don't have IBS. I'm not sure normal is very fair, but people with and without IBS. And you can see by the orange bit of the bar that people with IBS actually visit their doctors more, not only for gastrointestinal problems, that's the blue bit, which you'd expect, but they also visit their doctor more for non-GI problems. So there's probably a sort of healthcare seeking behaviour in a proportion of people with functional gut disorders. And it's a really, really big problem for us. It actually accounts for a massive part of our workload. As you'd expect, if you look over on the right there in sort of general GI practice, it probably accounts with all the functional disorders for about 40% of everything we see. So, you know, that's quite a lot, but I suppose that's fair enough. We are gastroenterologists. But look at primary care on the left there. 1 in 8 visits to primary care physicians in this study was about functional gut disorders, irritable bowel syndrome. So it's a massive, massive workload. And, you know, when you saw on that global graph earlier, something like 10 to 15% of the population in the UK have IBS or functional gut problems. So it is a really big issue. And not only is it a big issue, but it has a big effect on society and life in general. So here you will see that patients with IBS miss more work, miss more school than people without IBS. So about 3 weeks worth of absence in this study here for people with functional gut disorders. So it has a significant effect on the individual, but of course that has a knock-on effect on the economy as well. And I don't think I show you in this presentation, but if you look at some of the the epidemiological data about the economics of IBS, you see that it has a significant impact for us, not just in terms of healthcare expenditure, but in terms of work absenteeism as well. So what is IBS? Why does it happen? Well, the answer is really that it is complicated. There are biological factors involved, so we see alteration of the brain-gut axis, and we'll come back to that a little bit in a minute. We see visceral hyperalgesia, so patients with IBS have more pain from their organs, if you like, than people without IBS. We can demonstrate altered motility, and when I said to you there's no test for IBS, it's a slight lie, because if you stick balloons into people and measure their motility in the small bowel and things, you do see that there are differences there. It's just they're not terribly nice tests, and they're not really necessary to make the diagnosis. There may well be some genetic factors involved, although that's largely unexplored. We know that infection can be important. A good proportion of people who have IBS have what's called post-infective IBS. They get an infection and then they have a long-term change in their bowel habit afterwards. And then there are, of course, environmental things as well. But then there are psychosocial things that weigh into the pathogenesis of IBS. So there's a higher prevalence of psychiatric disorders. We know that people with IBS are more likely to have dysfunctional coping. So not only do they have symptoms, but they have more difficulty coping with those symptoms. Stress we'll talk about in a minute. We see a higher prevalence of disordered sleep, and there's a higher prevalence of childhood abuse as well. So you put all that together, the body and the mind, if you like, you see that it's a complicated biopsychosocial issue. And for different people, of course, different aspects of this will weigh into the process. So let's think about some of those biological factors, and let's think about stress. You know, what effect does stress have on the normal bowel? So this is my favourite ever study. I love showing this. This is about the effect of stress on colonic motility. So in this study, they took people having colonoscopies, and then after 10 minutes, they're going along and they say, la, 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 oh, I found a cancer. At the same time, they're measuring their colonic motility, and you can see that when the endoscopist says, look, I found a cancer, suddenly their bowel starts contracting wildly. Okay, they're under stress, their bowel starts moving, and then 25 minutes later, they say, no, I was only joking, you didn't have a cancer at all. And you'll see at this point that the colonic motility drops rapidly, which I suspect is because the patient rips the colonoscope out of their backside and hits the doctor. But you can see it all resolves then. I'm not quite sure you get that study through an ethics committee at the moment, but it beautifully demonstrates the effects of acute stress on the gut. And we all know this is true. You know, if you think of people before an exam, about half of people before exams get abdominal pain and diarrhea. It's just functional response to stress. And that's acute stress, but chronic stress will do this as well. And you can think of stress in the broader sense as well. You know, if you go and stay at someone else's house, for many people, bowels start working differently. People don't go to the toilet. Or you go on a long-haul flight, then people notice change in their bowel habits. So all this is stress on our systems, and you can see that it has an effect on the way the gut works. And that's because that gut-brain axis is an incredibly complex system involving the autonomic nervous system and also the hypothalamic pituitary adrenal axis. You put all of that together, you can see that stress in different ways will interact with that in different ways, and that then interacts with the gut in a very complex way. So it's difficult to predict exactly what stress will do, but we have to accept that stress is a significant trigger for gastrointestinal disorders. But so are other things. Eating, for example. So I bet you've all seen patients who come to you and say, oh, I eat and it goes straight through me and I go to the toilet within 5 minutes. Well, of course they don't, because they'd be dead if that happened. But this is an example of an exaggerated gastrocolic reflex, which is a very normal thing. If you have kids, babies, and you feed them, the first thing they do is they fill their nappies. Well, we do the same thing, not in exactly the same way as shown in this study. If you eat a meal, you will see that we get an increase in colonic motility. So the bottom line here is a patient without a functional gut disorder. They eat here and you see an increase in gut motility. But that becomes exaggerated when you have a functional gut disorder. So you see this person here with irritable bowel syndrome has an increase in that over time as well. And we also see that the responses to stimuli vary with functional gut disorders and normal people as well. Here you'll see that the response to rectal distension, so you stick a balloon into someone's bottom and blow it up, and this person at the bottom here who doesn't have irritable bowel syndrome notices that less. So this is a 1 to 10 visual acuity scale, where you put a mark on it. As you blow out the balloon, the person without IBS notices this less than the person with IBS. But interestingly, not only do they notice that with gut stimulation, but they notice it more with peripheral stimulation as well. So it's not just that their gut is sensitive, but they notice stimuli more than people without functional gut disorders. So those are the sort of biological things, but then there are the psychosocial things as well. And one can look at that in a variety of ways. Here we look at the prevalence of other disorders in people who have functional gut disorders, and it won't surprise you to know that other functional disorders affecting other parts of the body are more common in people who have IBS. So more migraine, more fibromyalgia, more chronic pain, and also more psychiatric disorder as well, anxiety, depression, bipolar disorders, etc. And again, we see this in everyday practice. It doesn't mean that every patient with IBS is depressed or has fibromyalgia as well, but we do see an increased prevalence of those coexistent disorders. But interestingly, we also see increased prevalence of functional gut disorders, for example, in GI disorders. So if you look at inflammatory bowel disease, we see vastly increased rates of irritable bowel syndrome there. And again, that's probably multifactorial. But I think if your gut has been insulted, if you like, then you will often see changes in gut function over time. I also mentioned about childhood abuse, and this is a really depressing slide, I think. But it shows the prevalence of sort of early adverse life events in people with functional gut disorders. And you can see here the astonishing prevalence of physical, social and sexual abuse in people who've undergone functional gut disorders. So here about a third of patients with IBS have experienced some sort of sexual abuse in their lives, which is terribly depressing. I guess it potentially opens a can of worms about what one does about that, and clearly I think it depends on what skills you have, and for most of us probably we don't have the skills to address this, but it's certainly something that's worth understanding and acknowledging. That some people with functional gut disorders may have deep trauma in their past, and it unfortunately highlights the fact that the lack of psychological support that we have in general in the NHS is probably a bigger problem than we realise. So that's sort of the why and where of IBS, but what do we do about it? And I think this, which is just, again, not to read, but is the nice guidance on irritable bowel syndrome, really says it all with the title, and that is that you need patient-centred care. You really have to think about the individual here. Because a good relationship with the patients results in patient satisfaction, it increases the likelihood of them following a treatment plan and therefore responding to it, and it increases the chance of them having symptom improvement. And establishing a good patient relationship is not necessarily easy, and it involves good communication skills and thinking about patient-centred interviewing as opposed to sitting there and just talking at your patients. I presented some data the other day about inflammatory bowel disease, but still it was showing that in the vast majority of consultations, patients reported being interrupted by the doctors when they're talking. And actually just stopping and listening sometimes is a much better thing to do. It's also important that when we see patients, we take them seriously. We do a thorough examination. We listen to what they're saying, but then we do appropriate investigation. Again, this is, I think, something that we often fail at when we're talking about functional gut disorders with patients and how we manage them, in that we over-investigate, because it's easier to sit down and say, oh, well, that test is negative, but we can do this test now, than it is to talk through what is actually quite a difficult and complicated conversation at times, particularly if patients want a positive test. And that leads to over-investigation, which is costly. And then if you think about some investigations like radiological investigations that involve ionizing radiation and endoscopy, potentially dangerous. So it's important to do an appropriate investigation and then to stop and say, we aren't doing any more investigations now because there's no point, and this is why. It's also really important to understand why the patient is there to see you, to understand what it is that they want from the consultation and to understand their concerns. Sometimes people with functional gut disorders, particularly at a certain time in life, as they get older, will just want to know that they don't, for example, have bowel cancer, which, let's face it, is a very reasonable thing to want. And in fact, when you talk through why they're there, and they say, well, you know, my friend had these sorts of symptoms and she got diagnosed with bowel cancer last week, you can understand why they're coming along to see you about these sorts of things. And it might be appropriate in that situation to do an investigation that rules that out, and they may need no further management. Equally, it might be much, much more complicated than that, but unless you delve into that, you're not going to know. And then finally, when you're thinking about explaining what's happening with functional gut disorders, you need to do that thoroughly, but you need to take into account patients' beliefs as well. And sometimes you have to adapt your explanation to what it is that people are likely to understand and what they want to hear. I think it's always useful to explain the role of stress, at least if people find that stress makes their symptoms worse, and I think that's the way to talk about it. Not that stress is the problem, but that stress makes things more difficult. You need to set realistic goals and limits, so people who've had IBS for 30 years and have tried everything and are coming in for their fourth opinion, you need to make them make sure they understand that they're not going to walk out of the door and feel fine the next day for the rest of their lives. They need to believe in and want whatever treatments it is that we're able to offer, or they just won't do them. And that's actually where dietetics is probably the greatest advance in functional gut disorder care that there's ever been, that's my concern, because fortunately most patients are interested in diet. And then, of course, from a physician's point of view, we need to involve other physicians, including primary care and other professionals like yourselves, so in the management of patients. And if you do all that well, then in fact patients tend to be satisfied, as shown by this. So this was a study in which they video consultations with patients with functional gut disorders and then graded them in terms of the strength of the interaction between the patient and the doctor. And you can see that if that interaction was poor, as we can see here, then the patients tended to come back again and again and again because they hadn't got what they wanted. But if that interaction is strong, then the patients don't need to come back because their concerns have been addressed and they know what's going on. So on to treatment, and this is probably a whole lecture in itself, but in fact it's quite simple. Okay, so diet I'm really not going to talk about very much because you'll be talking about that much more, but there are other aspects to the sort of more holistic approach to diet, to irritable bowel syndrome, and that includes lifestyle advice like physical activity, getting a reasonable amount of sleep, these sorts of things. And often, particularly if you work in central London where we're all psychopaths, that's why we live here, you will find that people are working far too hard and playing far too hard, and it's not surprising their guts are a bit up the creek. Beyond that, pharmacotherapy is certainly appropriate, and sometimes it's the right place to start. Often people will have been through simple pharmacotherapy either because they've used it themselves or their GPs have suggested it. So if people have diarrhea, the use of constipating agents like loperamide or codeine phosphate is appropriate. Equally, if people have diarrhea, then simple laxative, polyethylene glycol, Movicol, things like that can be really helpful. But one can be a little bit more directed beyond that as well. So specific problems such as bile salt malabsorption will respond, for example, to bile salt sequestrants. We're starting to have available drugs that interact with other aspects of gut function, such as chloride channel agonists, which will increase secretion into the gut, drugs that interact with 5-HT, either in a positive or negative way, therefore altering the gut function, treating constipation and diarrhea. And there's a lot going on in that area. But then, of course, we also have the sort of old-fashioned types of treatments we have. So amitriptyline, still often used for people with visceral pain and diarrhea. It slows down the gut, and it's actually quite a good gut painkiller. And indeed, SSRIs, the more modern antidepressants, have been shown to have benefits in terms of gut function beyond their antidepressant effects in those people who are depressed as well. And then there's the whole psychological side of treatment. There's a lot of interesting work going on in this. There's been a large multi-centre trial in the UK looking at CBT. There's a bit of evidence on hypnotherapy, psychological therapy. I'm sure we could all benefit from psychological therapy. And that's the sort of thing that you tend to reserve for second-line cases. Realistically, because it's actually quite expensive. You know, psychological therapy with a psychologist is one-on-one, often for an hour at a time, often for several sessions over several weeks. That's an expensive resource and is therefore reserved for more difficult cases. And then finally, complementary and alternative medicine, which is vastly used, probably because we aren't very good at dealing with patients and so they go elsewhere, is not encouraged, largely because there's a very limited evidence base to suggest it works. So you need to really think about patients on an individual basis. So you need to think about the symptoms they have. You need to address psychosocial issues. You know, to be honest, someone who's got rip-roaring constipation, predominant diarrhea is not necessarily going to do so well on a low FODMAP diet. But equally, patients who've got bloating, loose stool and some abdominal discomfort probably are going to do well. So you need to direct your therapy in the right direction. And if you don't get it right, and I'm afraid we see a lot of this, then dissatisfied patients tend to just go elsewhere or have unnecessary investigations and inappropriate treatments. So diet, obviously, I'm not going to talk about, other than to highlight that the low FODMAP diet is now a significant part of dietary guidelines, but you're going to talk about that and other things for the rest of the day. So to conclude, IBS is common, it's definitely complicated, but when you understand that complicated nature of the disease or the disorder, then you can start to address specific aspects of it. Management therefore has to be multifactorial, needs to take into account both biological and psychosocial factors, and you need to take your patients on that journey with you so that they will hopefully get the best improvement they can.